This UCSD TV program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest programs.
I'm going to talk about prostate cancer, although, I'm involved in this. This isn't my major area of study. I've been mostly involved in the pregnancy and lactation stuff, but this was interesting. It's done within my own university by a guy who's an oncologist, and he came over, 5, 6 years ago, and he says, you guys have an IND for your pregnancy study. I want to study it with some prostate cancer studies. And I said, yeah, great, let's do it. So he goes over to the head of our urology at the medical center, who was an Irish guy, and the guy listened to what he had to say and get out of my office. We're not going to do this. He says, we do serious research here, not vitamin research. And so after some cajoling, and I play golf with this guy, Tom Keene is his name. I said, come on, you got to have a fellow over here, give him something to do. And he finally gave in. And the results have actually been startling, and it's really transformed the way that they treat their prostate cancer patients within that practice. I have nothing to disclose. The objectives to identify prostate gland as a very vitamin D sensitive tissue, identify the vitamin D levels needed to protect the prostate gland, specify the safety of vitamin D in these studies in the absence of a U-shaped curve, although many people say there is one. There isn't. And identify the vitamin D that is important for the action on the prostate gland. So if we go to this slide, this was a slide when I was in graduate school. Vitamin D was really cut and dried. We knew the mode of action. It was all to do with bone and calcium homeostasis, and the sun made vitamin D and went to the liver, and it was activated at 25-hydroxy, and from there it went to the kidney, and it was 1-hydroxylated with parathyroid hormone, and the subject. Easy. This is what we thought, this was the end of the line. And this has been seen today. There's two different types of vitamin D, vitamin D2, which is dietary, and vitamin D3, which we make in our skin. We do all of our studies. We've done studies with D2, but almost all the studies now are all done with D3, although D2 is still used in the clinic because it's the only prescription form that's still available. Mike, when's that going to change? Yeah, so, and as Mike pointed out, a single MED of UV irradiation will produce 20,000 units of vitamin D released into the circulation within 24 hours. But if you're a person of color, you're going to need about 10 times that exposure to make the same thing happen. That creates problems for people of color at these latitudes, and here's a map that shows you, you've seen this today, in this area you can make vitamin D all year round. If you're in this area 1 to 6 months of the year, you can't. And up here, greater than 6 months, you basically can't make any vitamin D in north or south. Here's, which creates problems down here for New Zealand. Vitamin D and melanin. Basically, melanin is controlled by a cation exchange enzyme that was inherent in great supply in people of color. And this, in 2005, a guy named, I can't remember, it was published in Science. Anyway, they isolated this enzyme, figured out what it was. When it kind of disappeared, they mapped the genetics. It disappeared, or the mutation happened in Europe about 6,000 years ago when humans stopped being hunter-gatherers and became farmers and herders and planted crops, stopped eating as much meat. Until then, their diet supplied enough vitamin D, such as you had seen in the past. farming spread throughout Europe, and Europeans lost their ability to make melanin because of this change in habit and the pressure, I think, on reproduction that would not go forth if a pelvis that Dr. Hollis had shown in the beginning, you simply can't deliver a child. So by natural selection, the women who had lost this dark pigment and ability reproduce at a better rate. And it was published this was in Science. Now, this guy's really famous because everybody in vitamin D shows his picture. But it's really astonishing. This data was unpublished for many years, and it's a Prince Mesquite's lab. He's actually in Holland, but he grew up in Aruba, and so he does a lot of southern studies. And again, you've seen this many times. If you go to the Maasai tribesmen here and other tribes, their normal vitamin D level is up here. And if you look at a Bantu tribe, which is very close to these guys, except they're westernized, and if you look at them, then they look like we do, vitamin D wise. And here's the levels of fishermen in Aruba. This is in animals. So fishermen in Aruba have, and this is Prince Mesquite's data, they have really high levels of 25D. And so how did we come up with the levels that we use today and still are clung to basically by the IOM? All comes back to John Haddad in 1971 when they performed the first 25D assay, ran around St. Louis. This was done at WashU, collecting normal volunteers that could have been anybody who wasn't sick, worked in the physicians, absence of disease. They were 27 nanograms. Biliary cirrhosis patients, malabsorption, they were 6, very low. And then lifeguards, John had the foresight to pull lifeguards in, and they were quite high. Now, all this confusion about normal levels could have been eliminated if they would have said, okay, well, the lifeguards here, they're probably the ones that are normal. These aren't high enough. But you have to understand, to make that assumption, to get these people to this level would have required thousands of units of intake, which was totally against what everybody thought. So the perceptions drove the science didn't drive the perceptions. And another slide that is commonly used is that a lot of vitamin D measurements have had on old world primates. Here's your lifeguards, close to the old world primates living in natural environment. Here's a normal for us compared to what was said years ago, and still hasn't really changed. Here's somebody taking 1,000 and somebody over here taking 4,000, the levels that you reach. And it's amazing. I don't know, 7, 8 years ago, if you told somebody to take 4,000 units a day, they thought you were insane. That you were going to become vitamin D toxic. When Reinhold Vieth first published these papers, and actually I reviewed his first paper in 99 or 2000 that he published in, it was in Toronto. They gave 1,000 or 4,000 units to people for several months, and it was Journal of Nutrition or American Journal of Clinical Nutrition, and I was one of the reviewers, and they had the safety parameters, and I reviewed it, and I thought, this is really interesting. The other reviewer says this was unethical. They even did this study, even though there was no safety issues at all. And so the editors fought about it. Some of the reviewers did not want it published because they thought it would lead to vitamin D intoxication. And I fought back and said, it's not what the data say. The data say that there's no harm in this. So eventually it published it, and it was a very important publication because that publication allowed me to get things that we wanted to do on pregnant women through our investigational drug board. And Carol Wagner and I, in our initiation of our pregnancy studies, actually had to write an investigational drug application through the FDA to have those studies go forth, which was just unheard of. But they made us do that, and we functioned under an IND just like you would for a cancer therapeutic drug that a drug company would make. And was one of the reasons of this prostate cancer thing, because we had this IND, and then people would approach us and say, can we use your IND, access your IND to do this project or that project, and we would okay it. Food and Nutrition Board, based on the solid evidence linking vitamin D and bone, made a recommendation of 600 IU intake per day. All under indicator examined by the board, diabetes, cardiovascular, they said the evidence was not convincing. They said unless it's a randomized controlled trial, we're not even going to comment on it, except when they wanted to scare the crap out of everybody and said, oh yeah, well, there's a couple of, one or two studies out of 1,000 that said that there was a chance that there would be an increased incidence of neoplasia if you were above 50 nanograms. So they broke their own rule, ignored just an incredible amount of data to cite a couple that said they saw a U-curve in cancer incidence. And then put the warning, which still stands, is nobody should really have a level higher than what, Mike, 50 nanograms? So that was their, I mean, based on that evidence, they made that statement, which is totally preposterous. Endocrine Society that Mike did a much better job reviewing the data and much more comprehensive findings in the IOM, which just are laughable. The IOM did use a tolerable level of 4,000, and at the time we had the IND for several years at this level. So I don't know whether they took that into consideration or not. Safety-wise, another graph. If you just, this is from, I think you've seen this today in another form, but basically, the X's show vitamin D intake with hypercalciuria or hypercalcemia. There's one outlier here that is kind of weird, but basically, you don't see any, you get really high 25 levels at beyond 10,000 IUs of intake, and then you can see some vitamin D toxicity. The only vitamin D toxicity that's known is high blood calcium or high urinary calcium. There is no other. You know, when you talk about an induction of cancer, that's all hearsay. There's no other known toxicity reports for vitamin D that we know of. It's simply aberrations in calcium metabolism. Yes? Was it done with D2 or D3? There's all different things in here. Probably, this is a V thing, so there would be D2 or D3 in here, some of them. I mean, the highest doses, at least in the States, were always D2 because at the time, these are a lot of old studies, but it would be one or the other. And I can tell you from a safety standpoint that on our own studies on pregnancy, cancer studies, I've been on countless data and safety monitoring boards for all kinds of studies. You know how many adverse events we've seen due to vitamin D intake in these studies? 0. Not a single one. And so I keep saying, I mean, it's a terrible waste of money to assemble these data and safety monitoring boards and go through the reports because they're doing studies on intakes of 2,000 or 4,000. I say you're looking for something that does not exist. Stop hoping. But it's just senseless, but it continues on. No adverse events due to vitamin D intake. The time, again, the time has stopped to look for adverse events in intakes. There's really no sense to take more than 10,000 units unless you have some severe pathology, like I was talking to a friend about interstitial lung disease or multiple sclerosis or, maybe cancer incidences, but nobody. That's not physiology. There you're treating disease. It's a whole different ballgame. And you're not preventing it. People already have something that might need to be treated. And again, you've seen this slide with rickets, osteomalacia, normal levels. And this was a Joan Lappy study that Robert Haney showed earlier about the prevention of cancer in this study. Initially, it was a bone study that then you reanalyzed the data and got this remarkable results on cancer suppression. So we go through a more complicated slide of vitamin D metabolism now, where 25D can go to these different tissues and be turned into 125 for bone health, growth regulation, immunology, cardiovascular, neuromuscular effects, the things that you've seen today. And it's very simple. You have 70-hydrocholesterol, be converted to D3, D3 converted to 25D3 by this CYP2R1 enzyme, and then 25D converted by the 1-hydroxylase. And it binds to the receptor, and then the retinoid X receptor binds to that, and they attach to the response element in any given cell, and this nuclear drip complexes, and then it gets anti-proliferation, up-down regulation of many different genes that you find. Simple concept. Now, the hot thing now right now, and there was a New England Journal paper about this within the past year about free 25. Is it of any physiological circulating importance? Because now there's, quote, an assay to measure this, okay? And I've looked at this and our work with vitamin D, and from my perspective, I don't think it matters, okay? I think that the level of free 25D at levels of 25D that we're looking at, even 50 nanograms, is so tiny. In the free, to have the concept of this, free 25 would mean the molecule free from binding onto the protein that can get, if it's bound to this protein, it cannot penetrate into the cell, except in certain specific incidents, what I'll talk about. But say a prostate cancer cell, if it's 25D attached to the vitamin D carrier protein, it can't penetrate into that membrane because it's blocked by this cell. So there is a certain amount of that 25D by law of mass action that's free. And people have said, okay, well, this is the portion that matters, and maybe it does, but I'm doubting that that's the case, okay? And I'll show you the reason. And the reason is the alternative is vitamin D, the parent compound, because the free vitamin D, if you take free vitamin D, is much loosely bound to the protein. So there's free stuff all over the place. And free vitamin D all over the place is composed of 25D. And you can show instances of this, and I'll show you why I believe this in our prostate cancer data, and it's absolutely true in the human breast. Because in a human breast, vitamin D gets transferred from the blood into the milk at high levels. And as far as we know, there's no specific transport mechanism for that to happen. It's simple diffusion, okay? 25D could diffuse over, but it can't because it's locked onto carrier protein, and the transport is pathetic. So you could have a woman who's breastfeeding who would have 100 nanograms of 25D in its circulation, but for whatever reason, but hadn't taken vitamin D in a long time, her breast milk is going to be inadequate for her nursing infant. Okay, let's talk about vitamin D in the prostate. Okay, the human prostate cells express the vitamin D receptor. Normal prostate cells can synthesize 25D and 125, which remains sequestered in the gland. Now, what that means is the gland can take vitamin D that's circulating, it diffuses into the prostate cell, and the prostate has a 2R1 enzyme that takes vitamin D from vitamin D to 25D. And then the 1-hydroxylase, which activates it to the final form that has to be there to do its magic within the cell. And then, of course, 125 inhibits proliferation in cells. I'm not really here to talk about the 125, but that's the end product that does everything that I'm going to talk about. Now, here's a modern slide. We published this about a year ago, and it had to do with delivery of vitamin D into tissues itself, between vitamin D, 25D, and then ultimately 125. Vitamin D, the half-time in the circulation is about 24 hours. It's quick, and the reason is it's so loosely bound to the carrier protein. So that means that there's a tremendous amount of it at any given time that's not hung on to that protein. 25D, on the other hand, is ferociously bound by that protein. A half-time is about 2 to 3 weeks. So it's locked on there like glue and can't get off. There's just very little of it can get into cells. And then 125, I mean, basically 125 is all free. The half time is 2 hours. It moves, you know, as soon as it's made, it moves out of the circulation into any given cell. You know, when you look at these studies people have done in the past in vitro, and they put things in there, it's hard. But in a physiologic sense, all you have to do to look at these things is look at their half time and what their free concentrations would be in normal tissues. So as a consequence of this, vitamin D, okay, because it's loosely bonded to the protein, flows into human milk, which is, and Carol Wagner's going to talk about this in our studies. And then vitamin D can go every other. It flows into the liver. It'll go into these any given cell here. Breast, colon, skin, brain actually belongs probably not in here, but up in another class, ovary, prostate, cancer cells. These cells don't have an active system that other systems do. Namely, okay, the whole complex of vitamin D, 25D, and its association with the vitamin D binding protein can be actively moved from the serum through a megalin-mediated transport endocytotic system into the kidney. If you take this active system away, the kidney ceases to function, basically ceases to function in a meaningful way with vitamin D because it's lost its ability to take vitamin D. The other one that's megalin-mediated is placenta. Placenta, if you look at cord blood versus maternal blood, cord blood has about 70% of the concentration of 25D that maternal blood does. And that's because it's transported across with this megalin-mediated system. And they've done knockouts, especially in the kidney, where they've taken this out, and it just really obliterates the kidney's ability to metabolize. Other cells, and actually the brain probably belongs in this megalin-mediated in the nervous system, it's in here, but cancer cells don't have this system. So they're totally dependent about bringing vitamin D in a diffusible way, not in an active. So 25D doesn't get in. It's vitamin D that gets in. And then once it gets in these cells, like prostate, it has all the enzymes to take it all the way to the end for metabolism. And this is basically a cell cycle to the end of metastases and cancer progression. So there has to be a lot of steps for a cell to go into neoplasia. Now, this was one of the first things. This is kind of the stuff that the IOM looked at. They might have looked at this paper. But there were papers published for this is prostate cancer, using a reference, okay, of, this is in nanomoles. 40 to 50 nanomoles were a reference level. And if you went lower or higher, you got this U curve where above 80 nanomoles or 30 nanograms in all countries, Norway, the Scandinavian countries, your incidence of developing prostate cancer was higher than the reference. So Cedric showed you the declining curves. They made a big deal out of this, but this is, if you look at this, this really is some kind of confounding factor, because if this were true, you would see tremendous levels of prostate cancer as you went from north to south. You would see increasing rates because of more sun, and you simply don't see that. So what this, you know, this may be, this is probably more due to the seasonal changes in vitamin D going up and down than it is to the absolute number that you would see. But our own studies that I'm going to show you totally prove this to be ridiculous. So here's our prostate cancer study. Finally, we enrolled male subjects with early stage, they're low risk prostate cancer, meaning these guys come in, their PSAs are higher, their prostates are enlarged, they get biopsied, their PSA levels were 10 or less nanograms, and they had a Gleason score of 6 or less. So these guys, the treatment that's recommended by the urologist are active surveillance, which means go home, come back in a year, we'll re-biopsy you and see if you're worse. That's the treatment. So we said, I didn't, but the guy said, okay, how about if we give these guys 4,000 units of vitamin D a day for 1 year? You're going to biopsy them anyway in 1 year from now, and we'll have a look to see what's gone on with has it progressed, stayed the same, or gotten worse? So that's what this was an interventional study, the first study that they have, because no one believed it would be. Guy got a little bit of money. We got a urology fellow, and pathologists were reading these, and so the study went forth. And we also looked at PSA in this, but PSA in this was of no use whatsoever. So if you'd have been looking at PSA levels, how they were affected by this, you would have come to the conclusion that vitamin D was of no use. But that's not what happened. This is how the biopsy is taken in a man, and if anybody in here has ever had one, you can attest that it's not a pleasant experience. They go in through your anus, and they put this probe in, and you get these needles go in and draw 12 cores, and then they come back out, and the pathologist reads them. So when we did this, and at the end of our interventional study that wasn't done, it wasn't a randomized controlled trial, although that's happening right now. Once they did this data, they said, wow, this is pretty impressive. We're going to give you some money. It's a VA grant. We're going to let you guys do a randomized controlled trial, which has been going on. But the initial study showed, these lines showed in the treated people, the treated men, we had an actual decline in the Gleason and positive number of cores in our patients. Again, compared to matched patients in the same practice. Again, it wasn't randomized control. These were patients within the same, our university, read by the same pathologist, matched for everything we could match them for. And as you would suspect would happen, things usually get worse over time for these guys. They don't get better like our intervention did. And it was interesting in the studies that the ones on baseline 25D levels, that the ones who had the highest levels at diagnosis actually did the best when they were given vitamin D. So lower levels at baseline, even when we supplemented them, they had worse outcomes. And this paper was published in JCNM a couple of years ago. These were the 25D levels in the actual patients. So blacks and whites, closed circles, black patients, white patients, open circles. And at the end of all this, you see blacks were always lower in the beginning, but when we put them on 4,000 units, they normalized. Everybody basically at the end ended up with the same level of 25D. And the baseline, here were the baseline characteristics. Now, entry level, 26.8 nanograms, that's not horrible, 25D level. But then they wanted to do another study, and this is a randomized control, and this is really interesting. So you'll get some of these guys that are diagnosed with prostate cancer, and the doctor says, I want you to sit for a year and not do anything. Some of them go, you know, I can't do it. You told me I got cancer, I want it out now. And some guys do it on their own. A lot of times the wife is pressuring them to have it removed. However the decision is made, the standard protocol is once the decision is made, and you have to wait 2 months after the biopsy for inflammation to go away, retard, and then they'll do the procedure. So we decided that they were going to do a randomized trial, and what they did was the guys who elected for surgery, some of them were put on our 4,000 units a day for 2 months, and some of them received placebo. And then at the end of those 2 months, the gland was extracted, and then the guy standing right there, he gets the whole gland. So you can do all sorts of stuff on it now. You can do, and we did multi-mass spec scanning, and the genomics guys got a hold of it and did full genomics scanning of these glands, and this is where it really got good. So these are the subjects that I'm going to show you. The study's done now, In the end, what was decided was there's probably 30 more subjects. They wanted them all saved until the end to run them all at once through their genomics and electron microscopy scanning. But these were the subjects with the 25D levels, and you can see who was on 25D and who wasn't. So this person was, this person was, this person was not, this person was not, this person was not, no, yes, no. So just by looking at 25D, you know who's going on there, unless they're not being compliant. But you'll also notice on these levels that somebody with 35 or 36 nanograms, you wouldn't think would have a big problem with prostate cancer. But this paper came out maybe 2 or 3 months ago. And I don't know if it's in Science Daily. These guys, initially in 2006, found that they called it a prostate PDF, prostate differentiating factor. It turned out that it was really growth differentiating factor 15. At that time, they didn't know what it was. But they found it, and then they did this study, was just published in Prostate, okay? And what it did is linked, genetically, it linked GDF15, which is an inflammatory inhibitor, to severe prostate cancer invasion. And then using that study, which was just published in this, they said missing link between vitamin D and prostate cancer. It was GDF15, okay? You can go back and read this and read these papers. So I called the initiator of the study the day that I saw this, and I said, you guys have done heat maps now in the genomics of these patients that I've shown you. I said, what genes are lighting up on here? You know, look at that. The top gene, GDF15. These are heat maps. These tissue samples are given to our genomics core, and then what you have here is, these are the placebo vitamin D patients, and these are the ones that got vitamin D. Now, you ask yourself, there were changes in 25D levels in these patients, but they weren't big. But what changed big was the circulating vitamin D. It went from nothing to probably 30 or 40 nanograms on this protocol, where 25D really changed a little. But if it's free vitamin 25D that's acting, okay, and there are other instances, it's not that. It's the vitamin D that's in the circulation that diffuses into the prostate gland and causes the cascade to happen. And again, so GDF15 here is the top. You know, the one thing that's absent on here that didn't light up was a 24-hydroxylase. Now, that's a key, because 24-hydroxylase inactivates 125 from functioning within its cell. I would have expected it would have been on here, but it's not. So then what happens is the genomics guys, which are really mathematicians, you gotta remember this one at the end. This is the initiation of metabolic pathways simply by vitamin D treatment, okay? This is one mathematical model from the genomics guys that they gave us, and here's the other one. So this is what changed in those glands genomically by simply treating them with vitamin D. It's incredible, and what it does is it goes through the MAP kinase. MAP kinases are inflammatory, they're inflammatory processes. What vitamin D is doing here is cutting inflammation, and that's exactly what the guys who published that Science Daily with GDF15 said. It's a cutting of inflammatory processes that's having an effect on here. Now, does it have an effect on more aggressive prostate cancers? I don't know. And we did even more. These were the same patients that were scanned on it's a MALDI-MS. Basically, they take the prostate gland, section it, and take a $1 million mass spec, and they scan it for different wavelengths, looking for differences in proteins and lipids at different wavelengths. And the differences were with vitamin D treated versus no vitamin D for both. These were proteins, okay, were quite dramatic. Now, some of them, they were scanning here for thrombosin, this compound, proteins, and it was so noticeable that the mass spec scanner could tell right away who had been treated and who didn't, even if it wasn't blinded, or if they were compliant. And here's some serum lipids in these prostate gland slices. So the bottom line is there's really massive changes happening in these tissues due to this vitamin D treatment with only 4,000 units, with minimal changes in 25D, but huge changes in vitamin D itself. And so that leads us to the fact of that 25D circulating in some of these is not the only thing. It's important, but especially from the skeleton, but it's really important also to have adequate vitamin D. That's something that wasn't appreciated prior to these studies. And the only way you can make that happen is you take vitamin D every day. You can't take it once a week. You can't take it once a month. You can't take it, every 2 months, because the vitamin D disappears. You'll get a spike. We'll show you tomorrow. Spiking down, gone. Wherever it goes, it doesn't come back into the circulation. It's gone. And so you have no more parent compound, and you have no more of those compounds that can diffuse into tissues that would require it, that would have the machinery to take it all the way to the end. And again, I'm coming back to this slide to show you the importance of simple diffusion of these compounds into tissues that do not have the active ability to move the whole complex in. So the conclusions: in organ systems not possessing a myelin transport system, we believe the circulating parent compound is of extreme importance in tissue integrity. I don't believe that free 25, the whole thing, there was a New England Journal paper that came out a couple of months ago that was just terrible, and one of the reasons it was terrible is because of their key measurements were done wrong. They used a vitamin D binding protein measurement that they said that there was this big difference in vitamin D binding protein levels between blacks and whites. Well, when you use a test that doesn't fully measure the genotype in blacks, what do you expect you're going to get? And that's what that paper did. So the whole paper was garbage, okay? The big push on free vitamin D, free 25D, I don't think is probably worth pursuing. I think the action would be how much parent compound is there that can flow into the cells. That will make the difference. And vitamin D has the parent compound, not as a parent compound, but given it so it can get into the tissue. And there it will make profound changes in these tissues, where I don't think 25D will. And one of the things that put me onto this was, if you go back, is it Richard Gallo here at UCSD, the dermatologist? Well, Richard used our IND he's a dermatologist. They were looking at cathelicidin induction in actinic, in keratinocytes that were atopic dermatitis. And so they used it, and what he did was he gave 4,000 units of vitamin D back to these children for 30 days, I think. And he said, you know what we saw? We saw an upregulation of cathelicidin, sometimes 1,000-fold in those keratinocytes. And of course, they attributed it to the rise in 25, which was all 13 nanograms. Now, keratinocytes, you're not going to have that kind of a response on a 13 nanogram rise in 25D. However, the vitamin D, what happened there is probably went back to the skin, went back to the keratinocytes. It had the full machinery to metabolize it and went in there and did its job. And that's what I think, that's what was one of the things that really got me thinking about this. And it's almost impossible to look at vitamin D and how much would get into a given cell. You can do it in the breast milk, where you can see that. But when you're trying to measure fluid vitamins flowing into a given cells, it gets very difficult. So it's going to be hard to prove, but that is my feeling. And I would just like to say all these people involved, but this study is basically Tony Celli. He was the one who founded it, who's carrying it on. He's an oncologist, and he's just done a tremendous amount of work on this. Thank you.
We have time for a couple of questions.
What was the book?
Yes, sir.
Oh, yes, thank you very much. I was just curious, from what I saw of this, it seems like the adequate levels of this vitamin D are affecting which genes are expressed and which ones are not.
Mm-hmm.
And that's basically before this. I worked with different products that are similar to vitamin B12.
Mm-hmm.
That would be methylcobalamin. And those are also involved in methylating the genes, which basically say whether they're switched on or off.
Mm-hmm.
I'm just wondering if any of these data have been compared to levels of vitamin B12 in the body.
No. You know, I know that talk was rather biochemical, but there was just no other way to show the data.
Okay, good. What I saw from this was that it's all about getting the vitamin D into the cells so that certain genes could be expressed.
Yes.
And they can have an inhibitory effect on cancer, et cetera.
Well, yeah, there's also, I mean, it can be manipulate 2,000 different genes in, you know, in multiple ways.
Right. There's also a need for vitamin B12, which is specifically methylcobalamin, which it's a methylation of the DNA, which is also a switch on and off switch. And I believe they both have to be functioning as cofactors. That would be vitamin D and methylcobalamin. And I just wonder, because there's such high levels of vitamin B12 deficiency, if you had looked at any of these data and compared who had vitamin D deficiency, vitamin B12 deficiency,
Yeah, well,
and that, because you can get all the vitamin D you want, both cofactors have to be present.
Yeah, we haven't done that. In fact, the data that I showed you is the data on a few patients, and there'll be a lot more this month. To do the study that you're talking about, you know, I mean, there's no data like this. When you're looking at, you know, first of all, in the prostate, you prevent cancer. Yes, we can, you know, we can make core samples better. Oh, great. How do you do that? I mean, show us more evidence. So then you do the genomics part and say we're affecting all these genes that will at least affect inflammation and also expression of proteins and lipids on the, I mean, in the end, what do you want for proof?
Yeah,
I mean,
I'm just saying.
No, I understand.
If you could divide it up where there was a group with adequate methylcobalamin, then with the vitamin D, you would have really.
If I went to that study to these guys, they'd hang me. You know, I'd have to get $10 million from the NIH to do that, and that ain't going to happen.
I don't think you could do anything for them to hate you, Doc. Thanks.
So you were going into B12. Are you just wanting to know if vitamin D being more highly absorbable will dictate the results? Because in that case, people who can absorb vitamin D are usually magnesium deficient, vitamin K deficient, and like low levels of iodine in the thyroid. So like I don't think B12 is like singularly like going to make the results change that much.
These people have no malabsorption problems. These people all for vitamin D just fine. Yeah, John.
Studies, these dozens or hundreds of studies that look for vitamin D metabolites, the vitamin D enzymes in tissues that came away with conclusions that the 1-hydroxylase and the VDR were present in 33 tissues. Did they not look for the 25-hydroxylase?
No, they don't, because we've been fighting over which is the real 25-hydroxylase. I mean, it's just in the last few years that people have finally accepted that it's a 2R1 enzyme that's the one.
Oh, so they haven't
so
done them.
No one's been interested in it, John.
Ah, okay. Thank you.
Okay, one more.
What was the bottom line? After the 2 months, whose prostate was the best?
Oh, by far. I mean, so if you're all we can tell you, I mean, for after 1 year, you have less cancer. So the 2 months is that all we can tell you is there was tremendous different effects of vitamin D, probably positive. Basically what it does is shut down inflammatory processes. The prostate, vitamin D will make the prostate become less inflamed, and that's what the other authors in the prostate paper showed, that the prostate, once you had growth factor, the GDF-15 inhibited, then the neoplasia went crazy.
Was free PSA measured?
PSA was of no use whatsoever. Yeah, we measured all the PSAs. You can't, that's what I mean. I contacted the people running the VITAL study, and I said, if you guys are doing your study and you're looking at PSA to draw conclusions, don't bother. If we'd have been looking at PSA only, these studies would have stopped way back.
Bruce, there is an interesting support for the statement or the point that you've made that I think is worth emphasizing. One, you told us that the serum D level is itself of possibly critical importance, and you've shown some tissues which will take the D and are capable of taking it through all of the steps. Now, in support of that is some math, if you don't mind my introducing some mathematics at this late stage in the afternoon. The half-time for serum 25D has been reported to be in the range of 20 to 35 days. We've been using a figure 3 weeks, that's fine. It's at least that. Now, if you take a 3-week half-time and you calculate what that means in terms of the total pool that's turning over, that's about 4% per day. And if you take a look at what the concentration of 25D in the serum is, that predicts a pool of about 2.5 million nanograms of 25-hydroxy-D in the body. And if there's that much there, nobody knows where it is. However, if a good bit of that daily utilization is going directly in the form of D into the cells where the tissues themselves do the 25-hydroxylation, then you get away from that math
I think that's probably where most of it's going.
That could well be, but you see, that's
You can't find it, it's gone.
not been said anywhere else. This is.
It would go and get utilized and end up in the garbage bin, you know, after it's used as 125.
And that's unlikely.